Okay, so I've been tasked to lecture on accuracy of observations and measurements, and by the end of the session, you should be able to differentiate between accuracy and precision, apply and interpret tests for accuracy, and apply and interpret tests for precision. So, as clinicians, we're constantly collecting data and analyzing this data. So, clinical medicine requires constant data collection in the form of histories, PE, diagnostic tests, and we use this data to diagnose, prognose, and manage our patients. The data may be accurate in varying degrees, and this is referred to as your error. So error is the extent by which data is inaccurate. And again, like I said earlier, the data that you get or the information that you get may be accurate in varying degrees. So naturally, the word error implies making mistakes. And mistakes can have varying levels of gravity. So it might be innocuous, it might be serious or life-threatening. And syempre, the error may mislead the clinician. So when your data is in error, this data may mislead the clinician. So in clinical medicine, the goal is to reduce this error as much as possible. Medical histories, diagnostic tests, physical exams are never perfect. Lalo-lalo na mga diagnostic tests natin. So we need to determine or discern whether or not the diagnostic test is telling us what it's supposed to tell us and whether or not we can use this information at all. And how are we going to apply or use this information? Now, accuracy is the ability of a measurement to be correct. If a measure is not accurate, it is said to be biased because it deviates from the true value in either direction. So the mean or average of the measurements is equal to correct or true value, then this is said to be accurate. So if the average or mean of the measurements is equal to the correct or true value, then this is what we refer to as your accuracy. So an example of something that will affect accuracy would be poor technique. So on the left side, this figure shows the uh, correct way of measuring a child's height. So the child is uh, removed his shoes, is standing up straight against the wall with the ruler perpendicular to the wall, and the observer taking that measurement at eye level. Okay. On the right naman, this is the wrong technique. So the child is wearing shoes, so that will result in an error. And why will this result in an error? Because the sole of the shoe will overestimate the measurement by the height of the shoe. So if the height of the shoe is 2 cms, then that measurement will be off by plus 2 cm. Okay. Similarly, the observer is not at eye level with the ruler. She's looking up. So the angle of attack will result in a measurement which will be off by the same degree as the angle at which she's looking up. Okay. So precision is the ability of a measurement to give the same result or similar result with repeated measurements of the same factor. This is synonymous with reproducibility or reliability, and it is shown when all values are close to one another. So accuracy, the measurements are close to the true value. Precision, the measurements are close to one another. Okay. So this is a visual representation of accuracy and precision. We say that the measurement is not accurate, not precise, when the measurements are far from the true value and far away from one another. We say that measurements are accurate but not precise when the measurements are close to the true value but are far away from one another. We say that a set of measurements are precise but not accurate when the measurements are close to one another but far from the true value. And we say that measurements are accurate and precise when they are close to one another and at close to the true value. Okay, random error is non-differential error, which means to say that it has no direction. It can be either positive or negative. It does not distort the data in any one direction. If the random error is large, precision, not accuracy, is affected because distortion from true value may occur in any direction. And this is your error that occurs due to chance. And because random error occurs due to chance, it cannot be completely eliminated from a system. In contrast, your measurement bias is your differential error, a non-random, systematic, or consistent error in which the values tend to be inaccurate in a particular direction. So in the example kanina of measuring the height with the shoes on, the measurement will be off by the height of the sole, and it will be um, plus the measurement will be off by plus the height of the sole. So if the height of the sole is 2 cms, the measurement will be off by plus 2 cms. So the plus 2, that's the direction of the error. So these are errors that are associated with measurement, and they may be due to technique or the method of measurement. It may be due to the measuring instrument itself, like when the measuring tool is inaccurate, and the uh, and examples of this would include taking the height with the shoes on, measuring BP with a loose cuff, which will result in overestimation of the blood pressure, or getting the CBG with an uncalibrated glucometer. So subject bias are subject-related sources of error, and this may be due to physiological changes, or it may be due to the disease, the presence of disease. And factors which may affect subject bias that are related to the disease would include the spectrum of disease. Maybe a patient is severely ill or not, or has a mild disease. The natural history of disease, where is the patient at in the course of his or her illness, and energy, or when the immune system fails to recognize an antigen or fails to respond to an antigen because of repeated exposure. Okay. So an example of this would be your dengue titer. So your IgM and IgG typically rises only after the third day of illness. So because of that, your dengue titer, your IgM, IgG, it's usually undetectable before the third day of illness. And that's the reason why we only do your dengue titer after the third day of illness. Because before the third day of illness, it will be negative. Similarly, your dengue NS1 will only detect the illness during the first 48 hours of uh, fever because this corresponds to the period of viremia. And that's the only time that your NS1 antigen will be detectable because the NS1 antigen is a viral product and therefore it will only appear during the period of viremia. Okay. Similarly, your HIV test. So your nucleic acid test and your antibody tests, they all have a window period. So the window period corresponds to the time from exposure to the HIV virus until the time that uh, the test will detect the antibody. So before 10 to 33 days for the nucleic acid test, the HIV antibody will be undetectable, and therefore your nucleic acid test will have a negative result before the window period. So this is the basis kung bakit post-exposure to when a patient is suspected to have been exposed to HIV, we do the test after exposure and we repeat that test 6 months after. Because if we do the test early, then the test result is almost certainly negative. Okay. All right. Similarly, so this is an example of allergy. So category one are patients who are exposed to TB. So for example, a patient who lives with a relative who is TB positive, the positive PPD test is 5 to 9 millimeters. But a patient who is living in a non-TB endemic area who is TB naive, never been exposed to TB in his life, a positive PPD test is more than 15 millimeters. Okay. So intra-observer variability, I hope you observe this in your exercise. The same observer takes several measurements several times on the same subject, and there's bound to be differences in the measurements. Okay. Inter-observer variability, different observers take different measurements on the same subject, and there will also be differences in their measurements. So the example here is pneumonia on chest x-ray. So the left chest x-ray shows a clear lung fields, and on the right naman, this may be read as either clear or it may be positive for bilateral lower lobe infiltrates depending on the reader. Okay, so some radiologists might read this as clear, some radiologists might read this as positive for bilateral lower lobe infiltrates, and those infiltrates are shown on the arrows. Because alternatively, these could be blood vessels. Okay, so there are some people who will read this as positive for pneumonia. Others will read this as negative. Okay, false positive error. This is type 1 error, alpha error. Something is said to be true when it is actually false. False negative error or type 2 error, beta error. Something is said to be false when it is actually true. Okay, so this is your standard 2 by 2 table. I hope you were able to construct this from your exercise 3 for all 5 of those tests. Okay, so the gold standard for exercise 3, I believe, was the MRI. So condition positive, condition negative, gold standard. And your test of interest, test outcome positive, test outcome negative. So A is your true positive. This is your false positive. This is your false negative. This is your true negative. Sensitivity is simply your true positive all over true positive plus false negative. Specificity is true negative all over true negative plus false positive. PPV is simply your true positive all over true positive plus false positive. And NPV is your true negative all over true negative plus false negative. Okay? So ganun lang siya kasimple. Okay, so this is that again. So prevalence is simply your all of this, so A plus B plus C plus D. Your false positive error rate is B over B plus D. False negative error rate is C over A plus C. Your likelihood ratio is given by this formula, likelihood ratio positive and likelihood ratio negative. And prevalence is your positive, the sum of your disease positive all over the prevalence. Okay, all over the total number of subjects. So A plus B plus C plus D. Okay, so sensitivity is reliably diagnosing a disease when it is present and avoiding false negatives. So this is the proportion of people who test positive among those that have the disease, and it's given by the formula A over A plus C. The false negative error rate is the rate at which false negatives occur, and is given by the formula C over A plus C. Sensitivity plus false negative error is equal to 1 or 100%. Specificity is reliably excluding a disease when it is absent and avoiding false positives. This is the proportion of people who test negative among those that do not have the disease. It is given by the formula D over B plus D. And the false positive error rate is the rate at which false positives occur, or B over B plus D. Specificity plus false positive rate will be equal to 1 or 100%. Positive predictive value is the proportion of subjects with a positive result who have the disease. If a patient test is positive, what is the probability that the person has the disease? And it is given by the formula A over A plus B. Negative predictive value is the proportion of the subjects with a negative result who do not have the disease. If a patient's test is negative, what is the probability that the person does not have the disease? And it is given by the formula D over C plus D. Okay, so what is the effect of prevalence on positive predictive value and negative predictive value? For positive predictive value, prevalence is directly proportional to the PPV. And for the negative predictive value, prevalence is inversely proportional to the PPV. Okay. Sensitivity and specificity are unaffected by prevalence. This is because it cancels out. Um, So a screening test, which is used to rule out the diagnosis, should have a high degree of sensitivity. Sensitivity, when it is negative, it rules out. So hence the mnemonics down. A confirmatory test, which is used to rule in a diagnosis, should have a high degree of specificity. Specificity, when the test is positive, it rules in spin. Positive likelihood ratio. So this is the ratio of the sensitivity of a test to the false positive ratio of the test. And it's given by the formula A over A plus C all over B over B plus D. It's what the clinicians want in a test, which is a sensitivity, divided by what they don't want, which is the false positive rate. It indicates how much the odds of disease are increased if the test result is positive. Negative likelihood ratio is the ratio of the specificity of a test to the false negative ratio of the test. And it's given by the formula C over A plus C all over B plus D. It's what the clinicians don't want, which is a false negative rate, divided by what they do want, which is the specificity. It indicates how much the odds of the disease are decreased if the test result was negative. Okay, and this is how we interpret the likelihood ratios. So for positive likelihood ratios, a positive likelihood ratio value of more than 10 is a significant and often conclusive change. For the negative likelihood ratio, on the other hand, a negative likelihood ratio of less than zero point 0.1 is a significant. Okay. A large positive likelihood ratio and a small negative likelihood ratio is probably a good test. So, okay, for this example, they tried to use the 2 by 2 table to determine at what level of serum calcium detects the true disease status or symptomatic hypocalcemia. Okay, so this is how they determine the cutoff value. Um, so true disease status, that's symptomatic hypocalcemia, and this is serum level of calcium. So arbitrary though. So this is positive and negative test. Okay. So sensitivity is 60%, specificity is 95%. The false positive error rate is 5%. False negative error rate is about 40%. Positive predictive value is about 80%. Negative predictive value is around 80%. LR positive is 12, which is more than 10 and therefore significant. LR negative is greater than 0.1, so not that significant. And the ratio of LR plus the LR negative, the odds ratio is 28.6. Generally, as a rule, according to the textbook, a likelihood ratio that's greater than 50 is supposed to be a good test. And the prevalence of disease is about 25%. Symptomatic disease is about 25%. So, yeah, so that's how we make use of this. So is this a good test? So the sensitivity is relatively high. The specificity is higher. So is this a good confirmatory test or uh, a screening test? Okay. Okay. So this is a good confirmatory test. And ay sorry. Nasobrahan yata ako. So this is said to be therefore a good confirmatory test. Okay. Is this a good screening test? So the sensitivity is relatively high, so it's a good screening test. And the positive predictive value is quite high as well. Right? So receiver auto operating cutoff curve values. So this is the true positive rate on the y-axis, and the x-axis is the false positive rate. So what we want is a curve which is closest to this point, and that curve is this green line. Okay. Now the reason why we want it closest to this point is because at this point the true positive rate is high and the false positive rate is low. Okay. So the closer it is to this corner, this upper left-hand corner, the better the test. Okay. Similarly, for systolic blood pressure, we were able to determine that the systolic blood pressure cutoff value for hypertension is 140 because it is closest to this point. Now, the reason why is because at this point, the false positive error is low and the sensitivity is high. Okay, so if you get the distance between this point and this point, this is the shortest distance. If you compare it between the distance between here and here, and here and here, and here and here. Okay. All right. Similarly, for symptomatic hyperuricemia, that's also how they got it. So this is the value that's closest to this point. Okay. Okay. And then for troponin, the most sensitive test for myocardial infarction Overall, whether it's 3 hours, 6 hours, or 12 hours, will still be your chop I because it is the curve which is closest to this point. Okay, so agreement. Agreement is the extent to which observations of the same phenomenon differ. And if there is intra and extra observer agreement, a test is said to be reliable. So reliability does not equal validity. Both observers may report the same measurement or observation, but they may both be wrong. And imperfect agreement is not unusual. So using this standard 2 by 2 table, so so this is observer number one and observer number two, positive, negative observations. So A and D, so both observer one and two agree with the measurements. So A, both observer one and two agree though that the test is positive. And for D, both observer one and observer two agree that the test is negative. So D, observer 1 is negative and observer 2 is positive. C, observer 1 is positive, observer 2 is negative. Okay. So observed agreement is A plus D. Maximum possible agreement is A plus B plus C plus D. Overall percent agreement is the observed agreement over the maximum possible agreement. Cell A agreement expected by chance, as this formula. Cell D agreement expected by chance is this formula. Total agreement expected by chance, that's cell A agreement expected by chance plus cell D agreement expected by chance. And your kappa is simply observed agreement minus the total agreement expected by chance divided by the maximum possible agreement minus the total agreement expected by chance. Okay. So by way of illustrative example, so if you have two clinicians who are detecting the presence of a heart murmur, so observed agreement is 90, so 30 and 60. So 30 for the murmur is present and 60 for the murmur is absent. Maximum possible agreement is 100, so they just simply added the four squares. Overall percent agreement, that's 90 divided by 100, so that's 90%. So clinician 1 and 2 agree 90% of the time. Cell A agreement expected by chance, that's 12.2. Cell D agreement expected by chance, that's 42.2. Total agreement expected by chance, that's this value. So they simply added cell A agreement expected by chance with cell D agreement expected by chance. And your kappa is given by this formula, and they got a value of 78%. So their agreement with chance eliminated is 78%. Okay. All right, thank you. So I hope you guys were able to do exercise 3. So I hope you guys were able to come up with 2 by 2 tables and compute for the sensitivity, specificity, and accuracy for all 5 tests. And I hope so. If you guys have any questions, just go ahead and reach out to me, or uh, or ask away during the question and answer session on Tuesday and Thursday. Okay. So again, if you have any questions, just go ahead and let me know. And yeah, you guys know how to reach me. So yeah. All right. Enjoy the rest of your day.